Good evening to everyone, to all my seniors, my teachers, my colleagues, my friends. Today, the South India Neurological Academic Forum, the meeting is on neurology of vision. There are two topics, only for 1 hour, and from 25 minutes, I'll be talking on approach to visual aura and hallucinations. And the next talk is with Dr. Ambika, Professor and HOD of Neuro-Ophthalmology and Visual Sciences. Netralia will be talking on approach to acute visual loss. I will hand over the mic to both chairpersons, Professor Dr. Saravanan, Professor and HOD of Neurology at Tirunelveli Medical College, and Dr. Kanchana, Senior Consultant Neurologist from Erode, to start the topic and the lectures. And finally, they'll be coordinating the audience, the senior audience, and colleagues on question and answer session for 10 minutes. Dr. Gopi, could you mute all the mics except the people who want to speak? They can on their mic and speak. Dr. Gopi, I cannot hear Dr. Professor Saravanan voice.
Sir, sir can unmute and speak, sir.
Yes, sir. Yes, sir.
Sir, good evening, everybody, sir. Good evening, Professor AVS, sir. Good evening, Professor Natarajan, sir. Good evening, Professor Manu, madam, Professor Nadesan, sir, and my senior neurologists and my colleagues. And it is a great pleasure to join with all of you this evening to discuss two important topics in neuro-ophthalmology. We have to thank our Professor Dr. Palani, who is a legend, not only in neurology, but also in very many varied sciences like Thevaram, music, etc. He has got so many degrees in that. He is a founder of SINA, the South Indian Neurology Association, which is conducting regular meetings to impart academic knowledge to all neurologists. Dr. Palani is a mixture of a conventional clinical neurologist who is a keen person in eliciting clinical science, as well as far advanced modern neurology, who is well versed in recent advances and research arenas. It is indeed a gift to listen to him on very difficult topic of visual aura and visual hallucinations. There are many diseases like starting from migraine to occipital lobe disease like occipital infarct, occipital tumors, etc. And following that, Dr. Ambika is the HOD, Neuro-Ophthalmology, Sankara Institute. She will be talking on acute loss of vision. I had an instant to talk along with her, to discuss along with Professor Natarajan in Chennai in a meeting on neuro-ophthalmology when Nancy Newman, madam, came from abroad. And we were discussing about the treatment of brain intracranial hypertension along with Dr. Bhanan, madam. I remember Dr. Ambika, madam, was there. I welcome you, madam. And I request Professor Palani to take over the meet and talk on visual auras and visual hallucinations. Please, sir.
Thank you very much, sir. Can all of you see my slides? Professor Saravanan, can you? Yes, okay. Can I start talking?
Yes, sir.
I'll go to the slideshow. I'm sorry about that. Can all of you see my slides? Professor Saravanan, can you see my slides?
Yes, sir. Visible, sir.
Okay,
Yes, sir.
I'll start now.
Okay.
Sir, visible, sir.
So I'll be talking for 20-25 minutes on approach to visual aura and visual hallucinations. Visual hallucination is a perception of an external visual stimulus where none exists. Visual illusion is distortion or modification of real external visual stimuli. For example, distortions of size, micropsia, shape, metamorphopsia, color, dyschromatopsia. Visual hallucinations and illusions are clinically distinct phenomena but have overlapping etiologies. The visual hallucinations can be classified as simple visual hallucination and complex visual hallucination. In simple visual hallucination, it is basically elementary. The hallucinations are elementary and non-formed, like lights, color, lines, shapes, or geometric designs. Simple hallucinations of light can be phosphenes. It's called phosphenes. The visual hallucinations of lights without structure. Photopsias, visual hallucinations of lights with geometric-like structure like triangles, diamonds, and squares. Complex hallucinations can include images of people, animals, objects, or a lifelike scene. They are formed hallucinations. Visual hallucinations can sometimes be irritative phenomenon like brief stereotyped hallucinations and release hallucinations that are continuous and variable. Migraine visual hallucinations can be stereotyped and brief or variable and continuous. Hallucinations associated with the peduncular hallucinosis are often brief, but the content tends to be variable and not stereotyped. So in peduncular hallucinosis, you get a variable hallucination, but it is not stereotyped. If you take the retinal pathology, we have to start the pathology from the retina up to the brain and visual hallucinations. Retinal pathology like traction, irritation, injury, or disease of the retina can stimulate retinal photoreceptors, causing simple hallucinations in the form of flashes, sparks, or streaks of light. So it's very, very important if patient complain of these complaints to also think about retinal pathology, especially acute onset of unilateral visual pathology, because retinal symptoms are usually unilateral. Posterior vitreous detachment producing traction on the retina is a common cause of retinal hallucinations, particularly in older patients. Suppose an elderly person comes, he may be having Parkinson's disease, he may be on epilepsy drugs. So if he complains of acute onset of unilateral retinal hallucination, you have to suspect conditions like posterior vitreous detachment. Hallucinations associated with retinal pathology are not complex and the patient insight is intact. So the patient is aware that there is a problem and the patient come and complain to the consultant there is a problem and there is an insight of the illness is there and it is not complex. Intrinsic motion is a common feature of the hallucinations of light. So if you see this kind of light hallucination, which I have been talking about phosphenes and triangles and all those things, you can see something called intrinsic motion. Patients often describe flashes or flashing, whirls, shooting, lightning-like or spinning pinwheels. They are basically simple hallucinations. Unilateral hallucination, usually you have to suspect retinal pathology. You can see sometimes the intrinsic motion and patient has insight into the illness. That's very, very important. In many cases, the condition and the hallucinations are monocular in retinal pathology. Some conditions like cancer-associated retinopathy can affect both retina concomitantly, producing binocular hallucinations, and the hallucinations can occur in any area of the visual field. So it need not be a particular area; it can happen in any area. The remaining area can be normal. So if you see a bilateral symptom, you have to suspect cancer-associated retinopathy. It's very, very important to ask for an ophthalmologist opinion, even in unilateral or bilateral acute onset of this kind of simple hallucination, which patient come to the clinic and describe, even though you have other neurological problems. In retinal traction, Valsalva-like maneuver may be a trigger. Patient may say that with breathing or some kind of exertion, and the patient complains of these hallucinations precipitated, especially condition like retinal traction, which are viable by the Valsalva maneuver, the traction become more sometime. Frequent or persistent retinal hallucinations are associated with certain types of acute zonal occult outer retinopathy called as azure and the cancer associated retinopathies. If a scotoma develops after the onset of simple hallucination, patient complain of simple hallucination, then he develops a scotoma, it indicates a retinal injury that may become permanent if not evaluated and treated promptly. It's very, very important. Patient come to the clinic and say, I have hallucination, simple hallucination, not complex hallucination. And after that, he develops a scotoma. It is very important to ask for urgent ophthalmological opinion. It may be the local cause which is producing that, especially if it is unilateral. Formal visual field test, ERG, and serum studies for antibodies against retinal proteins like recoverin and enolase will give you a clue that it can be some kind of a cancer-associated retinopathy or some kind of autoimmune retinopathy, which I have mentioned. If you take the vision loss, release hallucinations, or Charles Bonnet syndrome, visual acuity loss or visual field loss from any cause affecting the eye, optic nerve, chiasm, tract, optic radiations, or visual cortex can cause visual hallucinations. It's called release hallucinations or Charles Bonnet syndrome. So any lesion in this visual tract sometimes can produce this kind of hallucinations, and it's called release hallucinations or Charles Bonnet syndrome. And the patient will have visual acuity loss or visual field loss associated with this kind of visual hallucination. So you have to suspect this kind of site of lesions which can produce this kind of symptoms. Older adult patients, what we know all of us, age-related macular degeneration, glaucoma, diabetic retinopathy, and cerebral infarction can produce sometimes hallucinations, and cognitive impairment and social deprivation are risk factor. You don't see this kind of hallucinations commonly in this patient, but people who are cognitive impairment, people who have social deprivation with this kind of etiology like age-related macular degeneration, glaucoma, diabetic retinopathy, and cerebral infarction can sometimes complain of visual hallucinations. Charles Bonnet syndrome versus psychosis. Absence of auditory or somatosensory hallucinations and other abnormal thought content. So patient thinking is normal, no tactile, somatosensory, auditory hallucination. Patient has only this kind of visual loss with this kind of hallucinations, what we call as release hallucinations or Charles Bonnet syndrome. That is a differentiating point from the psychosis. If you take the migraine aura, 15% of migraine patients experience aura. And 90% of aura of migraine patients are visual aura, because we know there are different types of aura in migraine, and the commonest type of aura is visual aura. Lifetime prevalence of visual aura of migraine is between 0.7 to 1.2%. We know the cause of the visual aura is cortical spreading depression, like self-propagating wave of neuronal and glial depolarization, which is the cause for the migraine aura. And we know that there is a condition called acephalalgic migraine, where patients don't have headache, you will have only visual aura as a manifestation of migraine. Migrainous visual hallucinations are usually simple hallucinations. As I was telling, simple and complex. Simple is unformed, complex is formed hallucination. Migrainous hallucinations are simple hallucination, unformed hallucinations, and typically linear or geometric, like zigzag lines in appearance. A classic visual aura is the fortification spectra. All of you would have seen the picture that in the fortification spectra of a classical visual aura of migraine. Scintillating scotoma is another visual aura of migraine. That is the area of decreased vision that is outlined by a hallucination with geometric design. You will have loss of vision surrounded by a this kind of geometric design, but everything recovered totally, including the visual loss. But I was talking initially about a persistent scotoma. After the hallucination, you have to rule out a local pathology like retina. So the scotoma, after the aura is over, the scotoma also disappear, and the geometric design also disappear. It is an unformed hallucination. It is not. It is a black and white. It is not a colored hallucination. Patients also see spots, dots, or shooting stars in migraine visual aura. Migraine auras tend to be black and white or monochromatic and are more geometric and linear in shape. Then you come to the epileptic visual hallucinations. It's often colorful and circular or spherical in appearance. So if you see colorful hallucinations, then you have to suspect that's an important differentiating point between the migrainous visual aura and the epileptic visual hallucinations, because this is colorful, that is black and white, that is unformed, and you see sometimes, many times, formed hallucinations also in epileptic visual hallucinations. Migraine visual aura can produce vision loss and visual distortions, such as appearance of heat waves and tunnel vision. Objects may appear smaller or larger, like micropsia, macropsia, or with a distorted contour. So you can see this kind of aura also, like small, big, or distortion, and for a brief period, that can be a manifestation of migrainous visual aura. Complex visual hallucinations are uncommon in migrainous visual aura. Suppose if the patient has a complex visual hallucination, like formed hallucination, colorful hallucination, is very, very uncommon, but have been described, but you have to be careful that is not the common manifestation of migrainous visual aura. Patients retain insight. In complex, this migrainous visual aura patient, even if they have this kind of hallucination, they know that there is insight of the illness. Migraine hallucinations are binocular. Usually, whenever you suspect a patient comes unilocular complaint, always suspect a local pathology like retina or glaucoma, or that kind of issue like neuritis, edema, kind of thing. Even though the patient complains of hallucinations in migraine only one side, but basically it is not, it is binocular. Many patients report monocular symptoms, misinterpreting the binocular. Aura can start in any area of the visual field, but usually begin in the central portion. So the aura start in the central portion. The growth or spread of the aura often from the center to the periphery over a few minutes. In seizure, it occurs in seconds. So if the visual aura, unformed visual aura, black and white visual aura, it takes few minutes to like form and disappear, then it is migrainous aura. But in seizure, this formed aura, complex visual aura, colorful aura, it happens within few seconds. So the time also gives a clue that what kind of aura we are handling. The usual duration of migraine aura is between 4 and 60 minutes. Retinal or epileptic hallucinations are brief. As I was telling that this epileptic hallucination, the colorful and the formed hallucination, in retina also the hallucinations are very brief, but migraine aura is a little longer. Prolonged migrainous visual aura are less common. Some case series have described patients with persistent visual aura of migraine not last month or longer, very, very rare, but don't depend on this. There are some case reports, but usually it's not very common presentation. It is rare for migraine aura to occur multiple times a day. So you don't get every day, like few times a day, like many times a day. Be careful. It can be some other cause rather than a migrainous aura. Migrainous aura don't happen multiple times a day. Epileptic visual hallucinations can be simple or complex. In a study of 20 patients, simple visual hallucinations localized to the occipital, occipitotemporal, and occipitoparietal region. Complex hallucinations localized to the occipitotemporal region and the temporal lobe. They do not occur in seizures restricted to the occipital lobe. So if we get a seizure only coming from the occipital lobe, formed hallucinations are very rare. Formed hallucinations, colorful formed hallucinations are very common in a combined lobar problem like occipitotemporal or occipitoparietal region. Pure occipital lobar seizure, only the seizure coming from the occipital lobe, and it's not very common to see complex hallucinations. Seizures arising from the occipital lobe, like bright colored circles or spherical patterns that may be multiplied or grow in size. As I was telling that, the like migrainous aura, the unformed aura, black and white aura, it starts from the center, go to the periphery, but in occipital lobe seizure, it can be colored, it can be multiplied, spherical patterns, and it grow in size. Motion is a frequent characteristic of epileptic hallucination. Whenever the patient describes, we have to ask all these leading questions. They don't tell routinely in the clinical setup. They tell whether it's colorful or black and white, and whether it grows from the center to the periphery, how long it lasts for. And sometimes patients, if you ask, they say this, there is a motion of the hallucination. Whatever they see, there is a motion, there is a movement component. The motion can be intrinsic to the hallucination. The movement can be within the hallucination, or the entire hallucination can move rapidly in seconds. So whatever that they see as hallucination, the whole hallucination can move rapidly in seconds across the visual field, the direction contralateral to the seizure focus. So we have to ask the patient, is a formed or unformed, black and white or colorful, and whether it is as a motion component and how long it lasts for. All these things give you a clue that what kind of hallucinations, what is the reason for the hallucination we are handling. It is stereotypical and visual illusions can happen. Epileptic hallucinations are binocular. As I told that, like when there is a migrainous aura, epileptic hallucination, they're binocular. Retinal and local ocular pathology, they're monocular. Many visual seizures do not progress to other ictal manifestations. Nearly all patients experience non-visual epileptic symptoms at some time. They can have a separate seizure component, and sometimes they can have only visual seizure. They don't progress to the ictal manifestations. Very, very important. All these questions give you a clue that are we handling a seizure phenomenon producing a complex hallucinations, or we are handling a migrainous phenomenon which is producing a simple hallucinations. Post-ictal headache is common in patients with occipital epilepsy. So it's very important to ask the patient that whether you have a headache. But you know that in migrainous aura also patient, the typical pattern is aura, then the headache and all those things. But you can get post-ictal headache. So we should not label that as a reason to say this is a migraine rather than an occipital epilepsy. So we have to ask the detail of the hallucination to come to a conclusion whether we are handling a seizure phenomenon or a migrainous phenomenon, because the headache alone will not give a clue sometime that whether it is a migraine or occipital epilepsy. Then we come to the dementia with Lewy body disease and Parkinson's disease. The visual hallucinations are complex, binocular, and occur through the entire visual field. So they see everything throughout the visual field, they see that. Well-formed images of people or animals to more abstract visions as shapes or colors. They see shape, they see color, they see the people or they see the animals. The insight depends upon the cognitive impairment. So if the people can have cognitive impairment with this kind of hallucinations, they may not be able to describe everything to the doctor, or they can have insight if they don't develop dementia, but they may have only hallucination, but they'll be able to describe that what kind of hallucination they're seeing. Sometimes there are people can even draw what they are seeing, what color it is, and how long it is lasting for. So it's very important to find out all the details, because for publication purpose or clinical neurology is sometimes interesting, even though we know that it is a dementia, the Lewy body, the myoclonus there, Parkinsonian features there, patient has hallucination. But if you ask all those details, it will be very interesting, and it also can give you a clue that over a long period of time that how these patients are going to behave, because every neurology patient is sometimes different from each other. The same disease. In diffuse, in dementia with Lewy body disease, visual hallucinations occur in approximately 2/3 of patients and occur early in the disease course, often preceding the development of Parkinson's disease. The patient can come with only hallucinations. They don't have PD features. So it's very important to pick up, and the history only give you a clue that we are handling the early visual hallucination feature of a DLB rather than the occipital lobe seizure or a migrainous aura. In Parkinson's disease, visual hallucinations are prevalent later in the disease course. So we know that in PD that there are so many reasons patients develop visual hallucinations, but it happens in the later part of the disease, not in the early part of the disease. The early part of the disease, it happens with the DLB, dementia with the Lewy body disease. Risk factors for visual hallucinations in Parkinson's disease are higher dose of dopaminergic drugs, dementia, advanced age, impaired vision, depression, and sleep disturbances. Alzheimer's disease and visual hallucinations. Sometimes we see the combination of the problem, and sometimes you see a pure Alzheimer's disease, and they can occasionally come with visual hallucination. But it is superimposed delirium, medication effect, or vision loss are the reason for the hallucination, not the pure Alzheimer's disease. And posterior cortical atrophy. So there are some patients with Alzheimer's disease, they can have focal cortical atrophy, not a generalized cortical atrophy. And if they have posterior cortical atrophy in the back portion of the brain, like cortical and occipitoparietal, occipitotemporal region, variant of Alzheimer's disease, in 25% of the patients, they reported visual hallucinations. It is not a typical, but it is a kind of a cortical dementia. Frontotemporal dementia, rarely people are reported. If you take the Creutzfeldt-Jakob disease, people have reported visual perceptual difficulties and visual hallucinations. Alcohol and benzodiazepine withdrawal can produce complex hallucinations with the vivid imagery. So very, very important to ask for the drug history also. Are they taking any drug? Are they addicted to some drug? They have some other medicines in the list which is producing this phenomenon. Very, very important to go through the list of the medications what patient is taking. Especially that when we before labeling a yearly phase of visual hallucinations of DLB and all those things with no other neurological features, very important to ask for the drug history. Medications are recreational drug use, like acute intoxication. Visual hallucinations are complex, bilateral, and full field. They can have confusion or frank delirium, often with auditory and tactile hallucination. That gives a clue that we are handling some other kind of problem. They're not only pure visual, they can have auditory and tactile hallucinations. Then drugs like digoxin, therapeutic as well as toxic levels, very important. We should not worry only about toxic level. Even a therapeutic level of digoxin can produce simple hallucinations of black spots, dots of light, television static. They see sometimes television static or a tint of yellow or green to the entire visual field. They complain of yellow vision or green vision. Even if there is a therapeutic level digoxin, you have to keep in mind it can produce this kind of a simple hallucinations. Sildenafil also has a weaker inhibitory action on the PDE6 located in the rod and cone photoreceptors. Blue tints to the vision. So yellow, green, digoxin, blue vision, sildenafil. An increased brightness of lights and blurry vision have been reported. Mild impairment of color discrimination at the time of peak plasma levels reported. So they can have color discrimination problem. They can have blue vision. They can have an increased brightness of lights. When people, I reported in people who take large dose or more dose of sildenafil. It's very important to ask if the patient complains that it can be a problem of sildenafil. So peduncular hallucinosis like midbrain lesion, paramedian reticular formation, sometimes it can happen in pontine and thalamic lesions. Visual hallucinations are complex in peduncular hallucinosis, binocular and involving both visual fields, vivid, colorful, more in the evening. Suppose they have more, it can happen in the morning, but more reported in the evening. So narcolepsy, the visual hallucinations are complex, vivid, colored images. Occurring before falling to sleep is called hypnagogic hallucinations, or just after awakening is called hypnopompic hallucination. So hypnagogic is falling to sleep, before falling to sleep. Hypnopompic is after awakening. While it is a feature of narcolepsy, community survey report a high lifetime prevalence up to 38%. This phenomenon in individuals without narcolepsy. So if I have seen one or two patients came to me with this kind of complaints, and they don't have any other sleep disorder symptoms or anything else, they found that there are some prevalence of the symptom of hypnagogic or hypnopompic hallucination. They don't develop narcolepsy, even a long-term follow-up. It can be a manifestation. So it can be a small mild presentation. So if you treat this patient, they do extremely well. It's very important to ask. So when you ask for the hallucinations, you ask for a simple hallucination, complex hallucination. So, and the simple is unformed, complex is formed hallucination, where it's black and white or colorful. It spread rapidly or spread over a period of time. That gives a clue as migraine or seizure phenomenon. Then ask for whether it hallucination happens while falling asleep or whether awakening in the morning, like hypnagogic or hypnopompic hallucinations. So all this history, like gives a clue that what kind of phenomenon we are handling and what is the diagnosis, and the treatment depends upon the diagnosis. The history is very important because the hallucination alone is not enough. And drug history very important. We have to ask for what drugs they are taking. Drugs like digoxin and sildenafil, which are commonly used. And there are times I have seen one or two patients reporting this colored vision like yellow or green, or once I saw sildenafil with blue vision. So then I thought, okay, what he is telling, but subsequently I found it is reported. It's very important to ask if the patient tells is go back and look the literature whether it has been reported. It's very important, all this history. It gives a clue that what we are handling is very important for treatment purpose and documentation purpose. If you take the psychiatric illness, visual hallucinations are complex, auditory hallucinations are twice as common and accompanied by visual hallucinations, lack of insight. The content is disturbing and antagonistic. That gives you a clue. And the background of the history of the patient, the way the patient look, all these give you a clue that we are handling a psychiatric illness. In metabolic encephalopathy, 27% delirium patients usually have visual hallucinations from a hospital series. So you see it's very common complaint. Not every specialist in their practice, not only neurologist, physician, critical care specialist, ophthalmologist, general physician, and the patients come to them and complain. Then you know that we are handling what kind of problem we are handling. So that's it. So I have finished with my presentation, and I request the chairpersons to introduce the next speaker for the next talk. We'll take the question and answer at the end of the sessions. Thank you very much.
Please.
Sir, shall we move on to the second topic, sir?
Yes, madam.
Yeah. Dr. Ambika, she is a senior ophthalmologist, director of Neuro-Ophthalmology Division. And most of the people in Chennai, they might know. And she is, madam is new to me. Madam, good evening. May I request you to proceed with your topic, ma'am?
Yeah. I'm starting my screen share. Is it visible?
Not yet, ma'am.
I think I have to close my.
You have to.
No, it's yours not seen.
We can see
No,
your
ma'am.
slides.
Yeah.
It, madam.
Yes, ma'am. Okay, seen.
At the outset, let me thank Professor PAZHANI for this opportunity. And it's indeed a pleasure and honor to speak in front of such distinguished neurology dignitaries. Thank you, all of you. And I really thank the chairperson for the introduction. It's indeed a nice opportunity to talk an ophthalmology topic to a shared specialty. I'm going to talk on approach to sudden vision loss from an ophthalmology perspective. So sudden vision loss is not something unusual for an ophthalmologist, and yes, it is an emergency. And most of the times we evaluate such condition based on the associated symptoms and signs. So it's very easy if we get clear ocular signs, as you see here, when there is a posterior segment disruption, it's most of the time a potential and vision threatening cause. And sometimes it can be life-threatening when the cause is going to be some neuroophthalmic cause. And unexplained vision loss and functional vision loss are conditions which do linger in this particular group, where a patient comes to you with a sudden onset of vision drop, but happens to have a condition which probably sometimes you may miss to make a diagnose, or it can be a simple malingerer. So we indeed need an clinical expertise and a comprehensive ophthalmic evaluation to decode such conditions because of their atypical presentations. And first of all, we have to differentiate what type of etiology it is behind the sudden vision loss, whether it's an optic neuropathy or a retinopathy or a macular cause, because most of the times these do lead us to medical legal pitfalls. So I'm going to discuss few of the common causes of sudden drop in vision, which can happen monocular or binocular. And I'm going to restrict this particular talk to cases mostly, which are interesting to this group of audience. So I'm going to discuss more on optic neuropathy and less on retinal causes, which I may touch briefly. So optic neuropathy, cortical blindness, retinal detachment, giant retinal tears, arterial occlusions, which can be central or branch, including the macular ischemic conditions, and traumatic sequelae can cause a sudden drop in vision. So as it is holding good, a detailed history taking is the key. So before a detailed history taking, you have to be very clear. I mean, before going for the clinical evaluation, you have to be clear what type of nature of onset was the vision loss. So if you're going to deal with an optic nerve related vision loss, it usually patient complains it's a sudden darkness or clouding or a smudged effect. And I see all the objects being bleached. The colors will be less vibrant, and sometimes they can complain of a earlier transient monocular visual losses, which can vary. And if it is going to be a field loss, it can be an altitudinal or an advanced field loss. Coming to the tempo of the vision loss, if it's going to be a monocular optic neuropathy, the patient can say it was a gradual progressive drop in vision. You're dealing something with a compressive. If it is going to be a sudden drop in vision, which had a spontaneous recovery after a while, to a better extent, it is invariably a neuritis. And if it is going to be a profound drop in vision, which did not have a great recovery and it plateaued off at a lower level, it's something ischemic, like an ischemic optic neuropathy. And if it is going to be a macular cause, most of the times patients can complain of distortion, metamorphopsias. As doctor has previously explained, we do have a lot of macular causes causing these sort of disturbance. So always rule out a structural cause for these symptoms. So blurring and an acquired hyperopia. A patient who is using a myopic correction can come with a sudden change in his spectacles. It might have been a macular edema, which is going to have a pushed hyperopic effect, and so his myopic shift would have changed. Post-traumatic or any systemic diseases and age-related macular degenerations do also cause such changes. So when we go to the clinical evaluation, always start with the basics. We do a good refraction, get a best corrected visual acuity, a color vision, and all the optic nerve function tests are a must. Pupillary examination, anterior segment evaluation by slit lamp, and a fundus evaluation. These are the electrophysiological tests, which definitely have a very good role, but you have to know which test to order when. And OCT and Humphrey visual fields are again very important in assessing such sudden drop in vision. AMSLERS is a good home testing for central scotomas, particularly when a patient has a central 20-degree of macular cause of vision loss. And ultrasound and angiogram will be having their role when there is an associated retinopathy. And any patient who is walking in with a mild vision disturbance and headache, we do default record the BP when there is a bilateral disc edema, because many a times, and I think of late, I'm seeing a lot of malignant hypertension surfacing during this pandemic period. So coming to the pupillary evaluation, if it is going to be a monocular visual dysfunction of optic nerve, invariably you can get a relative afferent defect because the other optic pathway is intact. But if it's going to be binocular optic pathway dysfunction, we will end up having a sluggishly reacting pupil. As simple as a pupillary exam will give us a vital clue whether are we dealing with a severe optic neuropathy or it's a functional cause. And if it's going to be an OCT, this has become one indispensable tool in the armamentarium of any ophthalmologist investigations, because it's going to give us the structural way how an optic nerve cube as well as the macular cube is going to be documented, and we can use this for the follow-up too. And these are the list of investigations, which is not new for most of you. And we would customize the investigation based on the etiology which is behind the sudden vision loss. If it's going to be an optic neuritis, in default, we are doing combined NMO and MOG antibody screening of late. And we also do a detailed autoimmune granulomatous and inflammatory workup. And nothing but not, thanks to the pandemic, we are doing COVID for most of the patients if they have a associated history or any recent infection along with the HRCT. So neuroimaging and definitely an MRI brain and orbit is more useful. And with these particular sequences, inversion recovery and a diffusion weighted imaging do have a definite impact to age the nature of the optic neuropathy. And CSF analysis as and when required, definitely we do ask for CSF pressure when we suspect a IIH. And the biochemical analysis will also give us a clue when there is a sudden drop in vision. So if we have a patient with a bilateral disc edema, first we will confirm whether it's a true disc edema. So if it's a true disc edema, is it associated with a vision loss? If it is yes, we are dealing with an optic neuropathy. And we evaluate that as an optic neuropathy. If there is no vision loss, it is not bilateral, we would go ahead, get an MRI for the rule out it's a structural lesion because we are dealing with papilledema. And if it is not, even then we are dealing with papilledema. So we go ahead and rule out an IIH or other causes for such condition. And based on optic disc swelling, so as I said, it could be, if there is a disc edema, it could be an optic neuropathy or a papilledema. If it is an optic neuropathy, it is usually unilateral. It could be unilateral or bilateral, but papilledema is invariably bilateral. And to begin with, there is a severe disruption of the optic nerve function. We are dealing with an optic neuropathy. If you see a disc edema with a good and preserved optic nerve function and a vision, then we are dealing with papilledema, because most of the times in early to middle stages of papilledema, the vision is preserved unless it's a chronic. And if it is going to be an acute vision loss, if it is painful, we are dealing with an inflammatory etiology. If it is painless, we are dealing with the vascular. All these will vary depending on the age part of it also. But there are something which are universal. If there is a gradual progressive painless visual loss, we are dealing with a compressive optic neuropathy. And as I said, if it is a sudden drop where we are suspecting infectious or inflammatory neuritis, optic neuritis, neuroretinitis, and posterior uveitis do form the common etiologies, where I don't have to tell about the first one, but neuroretinitis is not that uncommon because we do see significant infectious, para-infectious causes, which do have a disc edema and a macular star. Sometimes patients with posterior uveitis, where there could be a posterior scleritis with choroidal thickening, and there are multiple uveitic syndromes, which will cause a sudden drop in vision in young to middle age. So this is the classical optic nerve head swelling, where there is a sudden painful vision loss with a central scotoma and an MRI showing an enhancing signal along the right optic nerve. This is nothing but the optic neuritis. So if it is going to be a vascular cause, most of the time, as I explained, it's a sudden painless vision loss, which can be of a non-arthritic anterior ischemic optic neuropathy, because arthritic, invariably, the patients will have the other prodromal symptoms of a joint cell arthritis. So it could be a retinal vein occlusion, a papillopathy, or a CCF. So this is an example of a monocular painless sudden vision loss in a middle age, where we could see a what we call this is a pallid disc edema. And this is a classical altitudinal visual field loss. And if it is going to be an elderly person presenting with such condition, you have to rule out a giant cell arteritis, because it is not something which we can wait and watch. Every minute counts, and we do start the treatment as early as possible, and the tab as and when required has to be done. And going to be diabetic papillopathy. This is the picture what we see. Most of the time, the condition which causes this is because of the uncontrolled diabetes, where the symptoms can be to a certain extent reversed. And if it is going to be a central retinal vein occlusion, you can see a florid hemorrhages scattered along with the disc edema throughout the retina. And if a patient walks in with an acute vision loss, a high myope, or even age related, you could see this is the classical horseshoe tear, what we see. This is a massive retinal detachment regmatis, where there is this is a real ophthalmic emergency where you have to take the patient, and particularly the macula is being encroached. This is almost a shallow off where you can save the vision for this patient. And this is unfortunately a central retinal artery occlusion. If the patient doesn't land up on time, you're going to lose the vision permanently, and not a greater visual recovery. This is a classical cherry red spot of a central retinal artery occlusion. So let me go through a few clinical scenarios which we find in our day-to-day practice, which may be interesting to you too. And this is a 32-year-old young lady who was brought to us with complaints of sudden painful drop in vision in both the eyes for 10 days. And she was diagnosed elsewhere as retrobulbar neuritis. When we checked the vision, she was almost counting fingers at 2 meters in one eye, and she denied perception of light in one eye. And when I checked the pupil, both the eye pupils were briskly reacting light, and even the no perception light. So the rest of the evaluation was normal. So she denied that she could not do a visual field or a confrontation too. So we went ahead and did a VEP, which surprisingly showed good waveforms. So this patient denied perception of light in one eye and the other eye having a profound drop, but briskly reacting pupil and a normal VEP. This is a big no for RBN. So that's nothing but a functional visual loss. So this is a second case where the patient was a known case of RRMS on treatment by some local neurologist. And in fact, the patient was referred by MSSI for a routine ophthalmic evaluation. When I saw her, she was on interferon therapy. And she told me that she had some episodic mild vision drop, which was treated locally with steroids, and she improved. So she had a good vision. As a part of a routine workup, we went ahead. The OCT had a fairly good retinal nerve fiber layer thickening, and CSF was negative for a band in her history. She had an NMO antibody, which was done by ELISA, which was negative with her. And she was on interferon therapy. But when we repeated her NMO antibody in the cell-based assay, it was positive. So I gave a note to the treating doctor that such a condition is there. And that was last I saw her. But suddenly she came few days after with a sudden painful drop in vision over 2 weeks following a viral fever. Even then, she was on interferon treatment. She had 6/18 vision, sluggish pupils, dropped color vision, temporal pallor. And if you see that visual fields, these are dense inferior temporal quadrantine defects. That's, pathognomonic that the condition is sitting in the chiasm. So this was her repeat MRI, which showed there was an increase in the signals and the white matter lesions. Along with that, she had a dense thickening of the chiasm. So she had a chiasmal neuritis. So it could be probably an NMO spectrum disorder. So we advised her to switch to immunosuppressant. So she was on rituximab. Subsequently, she recovered, and this was her visual field post-treatment. And she was on maintenance of azathioprine, following which she maintained her vision and fields. So this is a 17-year-old girl. During her plus 2 exam, she was brought by the father saying that she was diagnosed locally as melingorine, and she had an absolutely normal fundus, but she's denying that she's saying that she's got a profound drop. She had almost hand movements, close face vision, and she had a very sluggish reacting pupil in both the eyes. So there is a bilateral dysfunction, and obviously the pupils are sluggish. So we are not seeing a relative apparent defect. So I ordered for a VEP where we saw a delayed latency and an amplitude reduction, which again confirms that we are not dealing with a malingerer and it's a bilateral retrobulbar neuritis. So she was put on intravenous steroids and followed with oral taper. She improved gradually in her vision, but her visual central field loss did not recover even after 2 to 3 months when I saw her last. And that was the last I saw her. And 4 years later, she came back for a routine follow-up when she was doing textile designing as a course. She said that I'm going to leave India for a higher studies. So I came to thank you. And her vision was 6, 9, and 6. And as I was talking to her, she came up with these history, which was shocking, sensation loss, unable to write, hold objects, poor bladder control. I said, girl, why didn't you go back to your neurologist after the treatment? She said, yeah, I thought that it may be because of my stress. But she had a temporal pallor with a central field defects as I saw her earlier. So I had told her, you repeat the MRI, please go back to the neurologist. You're dealing with something else. Before you're leaving, you have to get treated for that. And this is the MRI, what we see. So she's got a multiple classical Dawson's fingers, which are studded in the brain. And this is just 4 years after her initial RBM presentation. She in fact had a few small cervical cord signals too. So she was started on subsequently, this was in 2010, way back, I guess. That time we had only NMO antibody, which was negative. So she was put on interferons and her vision maintained. So this was an MS presenting initially as a retrobulbar neuritis. So this is a 25-year-old male, again referred, he actually noticed that he's having a poor vision in right eye. He noticed it suddenly. He had a past history of fever 6 months back, and he was treated for the fever locally. And he was referred as post-viral illness retrobulbar neuritis. So he had almost right eye vision of 6/12. In fact, even left eye, he had a mild vision loss, and both eyes, there was a color vision loss. Rest of the visual fields, fundus was normal. So when I saw this, he had a bilateral, this visual field showed that there are some central depression in both the eyes. And when we did a VEP, it also showed a reduced amplitude, but MFERG is this, which showed a definite non-recordable foveal, parafoveal, and perifoveal responses and a grossly delayed scotopic responses in the ERG. So that time he gave me a history that yes, he was put on chloroquine for a long time. And that was not a sudden drop in vision. Probably he got to know that because many a times our patients do not differentiate with the onset and accidentally noticing when the vision loss is, both are different. They don't understand that. So that was nothing but a maculopathy and that was not a neuritis. So this guy was again a 29-year-old male who was referred post-injury as a traumatic optic neuropathy. Yes, that's a ophthalmic emergency in an acute setting. So this guy had almost a 6/18 vision in the right eye and left eye was normal by all means. And when we did a visual fields, this is a classical secocentral scotoma. And when you see there's a subtle temporal pallor, and definitely this is not a traumatic neuropathy, which is 6/18. And this is something, to do wrong with the macula because you don't see the foveal reflex, you don't see the good macular hygiene. There is an abnormally widened FAZ. And the VEP also was relatively fine. But again, this is another visual, electrophysiological testing where pattern ERG showed a reduced amplitude of P50 with a normal N95 in the right eye, which pointing that what we are dealing is a maculopathy rather than the optic neuropathy. So that was a post-traumatic macular sequelae, what he had, and not an optic neuropathy. So this is a 36-year-old female who came with a sudden drop in vision in left eye. And again, all the evaluations were normal, no RAPD. And now the husband is saying that she's malingering. But when we did the visual fields, obviously she's not malingering. She's got definite dense field loss in the left eye. And what else? Because OCT normal, FFA is showing normal stain, but there was a late staining of the disc, which showed that there could have been some inflammatory process which is settled down. So then I said that it could be an acute idiopathic blind spot enlargement, a sequelae of a Mutes. Mutes is a multiple evanescent white dot syndrome where the patient has come 3 to 4 months later. So probably all those white flecks in the retina would have disappeared. And now all she has is only the blind spot where she does not require any treatment. Just follow her up 4 months later. And this is just 10 months later. So this is a 53-year-old lawyer who came with a sudden drop in vision in his right eye for 10 days. He said he had a childhood twin. So this is the condition what So this is a pallid disc edema in the right eye. And this was the presentation. So there was an altitudinal field loss of the right eye, and the left eye had already had a similar event in the past with a generalized visual field loss. So this is the visual field. He was just months back. So this is what we call as a bilateral NAION, and this is called a pseudo-Foster Kennedy syndrome. But he said, see, doctor, I have not come for an ischemic neuropathy. I have been incidentally found to have a pituitary mass. So my question is, should I operate, wait, will I worsen, what it is? So definitely this is not the mass, and the nature of the vision loss do not correlate. So there can be more than one cause for the drop in vision. So I said, this what you are having is because of the ischemic optic neuropathy. And subsequently, unfortunately, he worsened a few months later because of the worsening of his systemic risk factors. But obviously, there was a natural progress in the recovery, because ischemic optic neuropathies do definitely have some amount of spontaneous recovery, but they do not recover as good as the inflammatory optic neuropathies. So we have to be very careful that if we have to give the prognosis of such patients. So this is a 65-year-old male who was brought to us by the son. He was in fact seen in our free services with a sudden vision loss. His both the eyes pupils were brisk. He was only perception of light. He was brought in the camp for the cataract surgery. His fundus evaluation was normal, but he had a very dense cataract. So we went ahead and did a VEP, which was also good. And because of the media haze, there was a delay in the latency too, but still unable to explain because he was only perception of light. The cataract did not match with the vision. So we went ahead and imaged him, and this is what we got on the imaging. So he had an old PCA infarct on one side and a subacute infarct on the other side. So this was a cortical visual impairment, and we have to be, as an ophthalmologist, very careful when we go ahead and operate such cataracts, because it's going to end up in a very poor visual recovery post-surgery. So this is a 47-year-old female who was brought to us with sudden drop in vision of 10 days duration. You could see that she had been diagnosed as a thyroid eye disease or a CCF locally, because she had a past history of redness and diplopia and restricted EOM, which definitely is existing even now. So when we saw, she had definite gross, chemosis with redness, lid edema, and extraocular motility restriction. So in a way, we were also thinking that is she having any of those etiologies, what she was being told. But when we saw the fundus, she's got a bilateral disc edema, and the visual fields also showed bilateral central dense field loss. And this is her orbit MRI. You can see all the muscles being so grossly thickened, and this is not the very characteristic thyroid type of thickening, because it's not sparing the tendon. So I said that this is something else, and we have to rule out the other causes also. Although she's having a elevated anti-TPO, we were working as a IOID or a IgG4 disease or a myositis due to granulomatous etiology. So we had asked for a muscle biopsy, and her muscle biopsy showed a gross inflammatory infiltration, and we had a suspicion of sarcoid. So we put her on IV steroids followed with oral steroids, and immediately she recovered well, and her visual acuity also improved well. This is the last case. In fact, he was a 74-year-old gentleman, a father of a neurologist. So he brought to me, he said, like, see, he's 6'6". I don't know, my father is very uncomfortable after the cataract surgery, but he is very symptomatic. He's saying that progressively his vision is dropping. And this is what we call as a montage photograph. You can see on the whole, the retina, the vessel pattern. You can see some mild RP stippling throughout the retina, but almost the vessels are also slightly attenuated, but it looks grossly normal to us. And I said he's 6'6" and 6, but if you see the visual fields, it's constricted. He's having only a central island of vision. No wonder he's so symptomatic. So then we started investigating him. He denied of any systemic illness. When we did the ERG, he did not have any previous nyctalopia, but the ERG was non-recordable, almost like an RP patient it was. And this is something which is an acquired RP-like picture, which warranted us for evaluating the other causes for such conditions. So the VEP and systemic screening, when we went ahead, this is what we landed in on our HRCT. So this is a cancer-associated retinopathy. As Professor Pandey has said, many patients will give very subtle symptoms, like because a simple age-related macular degeneration or a posterior vitreous detachment also will come with a phosphine, and even this cancer-associated retinopathy also will come. So we need to be very careful in evaluating. And with an increasing incidence of all these malignancies, we are not surprised to see these conditions which were described in the textbooks, very easily seen in our OPD practice of late. So cancer-associated retinopathy and paraneoplastic optic neuropathy. And there are so many other retinopathy and malignancy-associated conditions, which I don't want to go in detail. They can be preceding, the vision loss can be preceding the malignancy too sometimes, because sometimes we don't even get a positive evidence of malignancy. Patients do land up years later to throw up the malignancy. So we have to be very careful, particularly when there is a progressive vision loss, nyctalopia, photopsias, photophobia, color vision problem. We do a detailed red rod cone function analysis on ERG, and these antibodies also to be screened in such condition. Unfortunately, most of the patients do not make it in spite of the vague promises given by the steroids and immunosuppressions. So nothing but not, the pandemic is also given us a lot of wonderful gifts to the ophthalmologist. Yes, we see a lot of COVID-related optic neuritis, cranial nerve palsy, stroke, cerebral venous sinus thrombosis, worsening of ocular myasthenia gravis, posterior uveitis. Last but not the worst, the mucormycosis is really making all the ophthalmologists run havoc, because it's really very bad in the prognosis, and we are getting a lot of patients referred from all the parts of the India. Unfortunately, most of them do not make it too. So to conclude, acute to subacute vision loss can be of optic nerve or retinal cause. Optic neuropathy can be picked by the tempo of the vision loss, and always correlate an optic neuropathy with the severity of the vision loss. If it is disproportionate, we have to be very careful in dealing with more than one cause. And maculopathy, it will be associated with rod cone dysfunction symptoms, metamorphopsias, photopsias, micropsias. And AMSLA testing is a very good home tool, which we can give it to patients when they have a macular cause for the drop in vision. And electrophysiological tests do have a vital role, but we have to be very clear in knowing what we are dealing with and choose the wiser one. So detailed stepwise approach will definitely help us in making the diagnosis, along with a proper neuroimaging for causes of sudden vision loss will be very useful in early diagnosis. So in neuro-ophthalmic practice, if you're not able to make a diagnosis after completing the patient exam, I think the golden rule we follow is go back to history taking. Thank you. Thank you so much, all of you.
Thank you, Dr. Ambika, for that wonderful talk. And all the cases I saw in this presentation are very new to me. And thank you very much for the very good cases I projected today. I hand over the mic to the chairpersons, Professor Saravanan and Dr. Kanchana, to coordinate the question and answer session. And I invite senior neurologist and my teachers, Professor A.V. Srinivasan and Professor Banu, to give their comments and opinions, any further enlightening. Thank you.
Thank you, Professor Palani. I request our teachers to enlighten more on this, sir. Professor A.V. sir, VN sir.
So please unmute the mic, sir.
Palani sir, you have discussed about the drug-induced visual hallucinations, and
Yes.
you told about recreational drugs and a few of the drugs. And one of the drug which we usually see is the triacylphenidine. When we put patients on a combination of syncopa and triacylphenidine, and most of the time the hallucinations occur because of triacylphenidine. And if you got a combination of drugs, stop triacylphenidine, last patient next week, and the visual hallucinations would have gone. So dihydroxyquinone is one of the important drug which used in practice causes commonly visual hallucinations. And another one is the cannabis. Cannabis uses mostly the quiet writers, etc. They use cannabis, and cannabis is the one which also gives rise to visual hallucinations. Sir.
Thank you. Questions from the audience, kindly unmute your mic and please ask the questions. The chairpersons, they will coordinate. Any questions? Any question in the chat box?
To Dr. Ambika,
Yes,
Madam,
sir.
you said it's something quite new. At least I have not heard about paraneoplastic optic neuropathy. How early it presents? Like we are taught paraneoplastic syndrome presents like a peripheral neuritis. You make out a malignancy after, say, at least 6 months, 3 months later. How often is that, say, you make out visual loss and a malignancy was diagnosed, or it was along with the malignancy it was made out?
Yeah, as I said, vision loss is the most of the time it comes as an unexplained vision loss to us, because most of the times it might be an optic neuropathy or it could be a retinopathy. As I showed that one particular patient, we don't have that many findings in the early stage. It can be very subtle changes on the retina. We have to get all this electrophysiological test. We have to rule out all the other possible causes, because sometimes we may not even pick up the malignancy in the early stages, as I said. And very few patients, what I have seen, in fact, we are trying to publish our series of neuroophthalmic manifestations of all these paraneoplastic presentations. We have seen with vision loss, with orbital lesions, with ptosis. These all have presented as a like a combination, unexplained double vision, unexplained vision loss. So most of them have been poorly evaluated in the early stages. We do go ahead, get the visual fields, get electrophysiological testing, get a proper neuroimaging. Sometimes I have in fact seen one of the senior city gynecologist who had a uterine malignancy treated long back, but unfortunately she came back with an orbital apex lesion. She presented with a 6 nerve features to us, and when we started screening, she had an orbital lesion at the apex, almost at the apex, orbital apex, presenting like almost like a 6 nerve lesion, a 6 nerve palsy with a vision loss. So it can be of a diverse presentation. It can have a vision loss. It can present like a double vision. It can present like an unexplained, ill-defined extraocular movement, muscle thickening. There are so many types of presentations. These all we put it together as a paraneoplastic syndromes. So if it is going to be a cancer-associated retinopathy, we have to deal with, we share these cases with our retina colleagues, because sometimes the retina people will say that, see, Ambika, this patient is very symptomatic, but I'm not able to explain in the retina for the findings. I'm not able to explain. Can you just go ahead and evaluate and let us know? And in fact, we have picked so many malignancies, breast CAs, we have picked a renal cell carcinoma, we have picked a lot of GI malignancies. All these have been present. In fact, I should say this, there was a guy who was referred to us from one of our ex-fellows in Maldives. So the patient was diagnosed as bilateral IIH. So he was a 30-plus-year-old young man with bilateral florid disc edema with a constricted visual fields. So in fact, the patient was referred to us as a chronic papilledema, IIH. But when we started evaluating him, because he had even a MR venogram also had a disturbance. So we thought it could be a venous sinus thrombosis. But one thing, he gave us a history that he had a frequent GI disturbances in the past, and he has been screened locally. But unfortunately, when we did a endoscopic evaluation, we picked a gastric carcinoma for that young guy. And in fact, the CSF also, once in a lifetime, I have seen a CSF showing a malignant cell when we repeated the analysis. So it can be of any type, but there are few cases which has remained as unexplained optic neuropathy, where we were suspecting it is a paraneoplastic cause, because these antibody panels and all cost a lot to the patient. And our patients, by the time they reach to that level, they are not willing to go ahead for the further evaluation of all these antibodies of recovery, enolase, and all those paraneoplastic antibody panel. The availability is also very less, and it's becoming really difficult. I think I should make a comment that we had even, and recently we have found a monoclonal gammapathy presenting as an optic neuropathy to us. In fact, when I check the literature, we are writing it up, we have never seen more than a case as MGUS presenting with optic neuropathy. So we are having one guy like that with us.
Thank you. Thank you so much for the beautiful explanation. Next time, we do see some of those lateral rectus palsies, no diabetes, MRI is normal. I simply tell them it's a viral demyelination, especially in a small setup. So put him on some steroids. We don't follow. Maybe next time I must to evaluate for a malignancy, at least what best investigations could be done. I think other people can share if they have come across.
Madam, Dr. Ambika, madam, Dr.
Yes.
Anand, one
Yes.
question. This post-COVID mycosis, how many cases of blindness to come across, and what is the cause of blindness? Is it thrombosis?
It's optic nerve edema.
It is multifactorial. Most of the times, it depends on which level. And rather than having a vision loss, we have lost most of the patients. They are not anymore with us. We had almost in this last few months, we had 22 patients, if I remember, after the lockdown release, what I have seen. And only 2 patients we are able to at least keep them alive. And almost 20 patients lost follow-up. The 2 patients who came, one guy, still the vision has not recovered because he had a central retinal artery occlusion, because he had only the sinus involvement, and to a certain extent he had orbita. But the ones which had the rhino-orbital sinus, they don't make it.
Thank you.
Madam, regarding the mucormycosis, if the patient has got only an orbital cellulitis, the retrobulbar amphotericin, how it is useful, or we want to go with systemic amphotericin also?
Madam,
We are having mucor ward separate mucor ward Erode Medical College.
So your question was, if you have only orbital, what you do?
Only orbital, yeah.
If it is going to be only orbital, we are going to have definitely the complete evaluation. We do a nasal endoscopy, screen whether, because many a times the nasal part of it is not evaluated properly. And from the onset of symptoms, like they may have a simple nose block. Many times I have seen that nasal endoscopy report saying that it is only a turbinate hypertrophy. God, it was not a turbinate hypertrophy. It was the fungus which is growing inside. So we do confirm with the nasal thing. With a close follow-up, we go ahead because we have to give a systemic amphotericin, and liposomal amphotericin does have a role. But because of the poor availability, posaconazole also has been tried for a few instances. We definitely do an exenteration and a debulking of the fungus as much as possible.
Any further questions from the audience?
Dr. Parni,
Yes, sir.
when will you be presenting a correlation of your ARA and EEG finding, MRI? When can I have, maybe the next time?
Yes, sir, we'll do, sir.
That should be more
Interesting.
useful, like, yeah.
Yes.
May I ask a question, sir? Like, this is Dr. Kavita
Yes,
from
Dr.
Madurai.
Yes.
Sir, ma'am, I would like to first congratulate for the excellent, such a lucid presentation. I would like to know from Dr. Ambika her experience on anti-MOG related optic neuritis or retrobulbar neuritis, and also the role of steroid versus rituximab for the management. And how do you follow up these cases, ma'am? What's your comment on this?
Madam, we are coming up with our results of zero markers, because in fact, now the one which is going in the publication process, let me share that experience with you. We have evaluated in this last 2.5 years, because we started doing NMO antibody in 2012, but MOG is available only in this last 3 to 4 years in India. We were able to access. And in fact, we are doing in-house MOG as well as NMO for all our neuritis patients. In that study, what we found in this last 2 years, we had almost 203 optic neuritis patients recorded in that study, of which almost most of the group, I would say maybe 50 plus, were MOG positive in that. So all our patients who were MOG positive, in fact, they were being treated as crayon earlier elsewhere. So in fact, there is a diagnosis of exclusion terminology only, I guess, is crayon. All these MOG patients had presented with a disc edema. They all had signals in their optic nerves, which was quite anterior, and they all responded to the steroids. But by the time we come down on steroids, they did jump back with recurrences. So MOG was having a higher prevalence in our group. And in that 203 patients, I guess around some 20s only had an NMO antibody, and only 3 to 4 or rather 5 maximum would have been MS. So when we come in that chronology of, antibody levels, MOG was first, followed by NMO. And in fact, we had a huge chunk of patients who were double negative. They were having optic neuritis. They were not having radiological evidence of MS. They were not having serological evidence of any of these markers. But still, so we kept them as double negative because they may boomerang back as one of these antibody positives probably in the future is what I guess. So for all our MOG neuritis, we keep them on IV steroids with slow taper of oral steroids. By the time we come down on steroids, we keep them on an immunosuppressant if they recover their vision. But if they do not recover their vision, we escalate the treatment from IV steroids. We directly go ahead. Although they say for a plex, many of our patients do opt for a rituximab for the cost effectiveness. And we have also seen very good response to rituximab in our group of patients. Hope I have answered your question, madam.
Sir, may I
Yes,
add?
ma'am. Thank you. very
May
much.
I add something, sir?
Professor Lakshmi Narasimhan, yes, sir.
Yes, sir. So in fact, the most of the cases with profound loss of vision, even 5-6 months, not refractory to steroids, they come to us. We start rituximab pretty late in the illness. In fact, even bilateral loss of vision due to MOG, 7 to 8 cases where we started rituximab very late. Maybe about they presented to us after 6-7 months. But even after 7 months, I was surprised that in spite of the OCT showing lot of significant fiber loss and all, we gave rituximab, and most of the patients developed useful islands of vision. So I thought it is always worth, in spite of being late in your therapeutic intervention, it is worthwhile trying rituximab because it's pretty useful. And we have it free of cost. Any patient whom you really want to refer, please, you can use our facility because we are able to give them regularly, sir, on a regular basis.
Chairperson, this is Dr. Natarajan. Can I ask a question of Dr. Ambika, please?
Yes, sir.
Please, sir.
Ambika, madam, I heard
Yes,
you
sir.
saying, I just wanted you to repeat your statistics. If I heard it right, out of 203 cases, you said over 50 cases had MOG antibodies and only around 8 or so NMO antibodies and 3
Around
MS.
20, sir.
Sorry?
Around 20 plus had NMO.
Okay.
6
Okay.
to 7 had MS.
MS.
And
Okay.
almost 70 plus had double negative.
Coming to that, yeah. So almost 50, 20, 70, 75 would have had these 3.
Yes,
MOG,
sir.
NMO, and so you had a large group of 128 patients left. Were all of them double negative?
I don't get. The remaining patients, are you asking that they were double negative?
Yes, madam. 203. Let's say 50, 20, 6, whatever, 75
Maybe,
or 78?
maybe I will just check the number, but this is the gross number what I could recollect. But definitely
So-
there was a huge population of double negative.
Okay, so coming to that, where are we now with regards to the testing when we have the largest proportion of people happen to be double negative?
Okay.
So how do we proceed? It's neither NMO, it's neither MOG positive antibodies. So what do
Sir,
we
the-
consider them as and proceed to treatment, particularly long term?
Depending on the vision recovery and depending on the other imaging and neurological signs, we can separate them, sir. If the patient has got a good recovery and the patient has not come back with recurrences, so probably we keep them on a watch when there is no radiological evidence. And we always have the neurologist to guide us, because there are so many times when these seronegative, they may behave with poor recovery. We keep them as seronegative NMO. When the vision has not recovered, we would escalate the treatment to the next level. Based on the response of the treatment, probably from the ophthalmic point of view, I can guide in that condition. And the neurology evidence and the imaging evidence also plays a vital role in the decision of which line we are going to move on.
Is there any point in repeating the antibody test?
Maybe unless the patient is having a relapse or a new sign, maybe it may not be worth in a short interval.
Thank you, thank you.
Sir?
Yes,
Sir,
Lakshmi.
can I, sir, one,
Yes,
can I
Ellen.
add some? Sir? Yeah.
Dharalma, solunga.
Yeah, yes, sir. One was there are a lot of there is a cluster of newer antibodies like recoverin and enolase and all have come.
Recovery அவங்க சொன்னாங்க, அவங்க பேசினாங்க.
No, sir. Recoverin and enolase and all these most of these double seronegative. There are 6-7 antibodies have come into place, sir. I don't. Nothing is available here, but in fact last the NANO, the Neuro-Ophthalmological Conference, which was held in March. Most of the cases, I was surprised that they were presenting. The story was more on these newer antibodies rather than MOG, and I was really surprised because a lot of cases were presented on that. When I attended virtually, I was able to see that these newer antibodies are on the rise. Probably this madam's big double negative, seronegative would turn into one of these newer antibodies also. Second thing regarding there are enough papers which say that the first time NMO is almost often negative, and it is a second, third, fourth, the yield of NMO positivity becomes higher. And there is one Japanese paper which says on 10th time they have picked up a NMO, whereas 9 times it has came negative, sir. So I think it's always worthwhile repeating the NMO at a later point of time than the next attack. Thank you.
Thank you, Ellen.
Thank you.
Sir, what's your experience on Plex, sir, in such conditions?
Madam, we regularly do. We find very good results.
Okay.
When we ran out of IVIG for MS, we just do for all the cases of all notice we do Plex. We get good results.
Okay.
இல்ல நான் எம்எஸ்ஓ என்னக்கும் பண்றீங்களான்றது தான் கேள்வி.
Sir, I am sir.
நான் எம்எஸ் ஆப்டிக் நியூரைட்டிஸ்க்கும் பிளெக்ஸும் ஐவிஐஜியும் உண்டா?
Sir, refractory to rituximab we do Plex.
Okay.
Two cases been referred from Trichy where they have tried 2 doses of rituximab, but till they did not get it, they came to us and we started them on Plex and they showed some improvement, sir.
Thank you.
Thank you.
The question to my teacher, sir, does the steroid influence the antibody level at paparin? Because whenever patient comes to the ophthalmologist at a mafsil or in a rural township, they immediately start the patient on steroids. So the steroid influence the antibody titer level so that you don't pick up, so that it gives a false negative in NMO. In finding out MOG antibody or appropriate for antibodies.
If it's a reasonably good titer, I think, madam, it doesn't make a difference with or without steroids, because this was one discussion what we had in our demyelinating group meet. because most of the patients will be treated elsewhere and referred to us saying that patient has not responded. So you have to go, and many of them don't even have the serum markers done even for first time. So when we start the patient, so definitely they are post-treatment, they have not responded, they don't have the serum markers. That is how we start our evaluation. So we have seen patients even post-treatment showing with if their titers are good enough, they will definitely come up with a positive result is what I feel. Probably the seniors should also share their experiences.
Vrinda,
Finding?
Yes, sir. Your opinion, sir.
No, people have been too much talking on the brain and the spinal cord.
Yes, sir.
Let the mind there. So it would be an excellent finding if we can take it. The colored auras.
Hey, we can't hear you properly. Audio is not that good.
No, people are now really gone through an excellent brain and they study everything. We have left the mind. I just wanted PAZHANI to study the mind because it has been well stated that the color of the arrows, especially the auras, give you the personality of the individual. This is something which is very interesting. If you take the color Vibgya, violet is of course the purple, which has got a higher consciousness in them. If anybody has a purple aura, watch out, he's got a higher and then spiritual awareness. If he has got what we call is an indigo, he has got lovely insight and deep, he can easily solve the deep problems. If he has a halo of blue, his communication skill will be excellent. And you can just study this behavior pattern. If it is green, they have a healing generosity. They are ideally suited for doctors to have the green auras. And then the yellow auras, of course, it gives you optimum and then the freedom. And then above all, the reaction is also very fast of them. And orange, they are absolutely excited even for a small one. Red indicates passion and physical. In other words, if you go from Vibgya, violet to the red indicates a physical concept, and then the indigo or the purple gives you the, what I call it as the spiritual concept. This is one side. I think you can take the Dara when you are studying.
Sir, Professor A.V. sir,
A.V.
sir, can I interpret? Or,
yeah, please.
One physics wise, violet has got the lowest wavelength, and red has got the highest wavelength.
Exactly.
That is why we use red as a danger light, because it can be visible even from a far off place, and violet will be the last thing that could be visualized.
Violet,
because it got the lowest wavelength.
I agree.
No, I'm just trying physics, nothing more.
That's a very interesting point, because that is there you read. We always say Sachidanandam. Sachidanandam is a potential energy. Chitta is a kinetic energy. When it is of a lower frequency, you are able to see the reality principles better.
Probably better. Yes.
That is getting into philosophy. Now, the second point I wanted to ask you was this migraine. They have fixed the seconds for the between the migraine aura and the epilepsy aura. I think it is 20 minutes, 10 minutes, and 30 minutes for the migraine aura. The larger the time migraine aura, the shorter the time is, which is about 56 seconds to 30 seconds. And the migraine, but maximum is about they divide it into first quarter, second quarter, third quarter for analysis. So each quarter has got 56 seconds, 20 seconds. So the epilepsy has a shorter duration, apart from the color that he has mentioned. Specificity and sensitivity of the aura is 100% is sensitive, 92% specific. I am interested in, Dr. Ambika, the epiretinal membrane. These epiretinal membrane cases, I've had 2 following up the post-COVID cases. They became not able to read the central vision. At the end of the 5th day, when the taste recovered, smell recovered, the recovery of the central vision also recovered. Have you seen such cases in you where they have recorded on OCT the epiretinal membrane? When he had the first injection, he had the visual problem. Second injection, visual problem. Third, when he got the corona, in spite of having the 2 injections, he really went into, once again, the diminishing vision due to epiretinal membrane. And all the time they have done the OCT in Bangalore and he has improved. Have you seen this occurrence? The moment he reached the 7th day when the taste recovered, the retinal membrane also decreased and he became vision is improved. Have you seen this epiretinal membrane improvement or involvement in Madras?
Sir, if it is a monocular vision loss, and is it definitely associated with the COVID, I would like to rule out an optic nerve cause also in addition for the central vision loss, because many a times epiretinal membrane and can also cause central scotoma, and an optic neuropathy, also a subclinical optic neuritis, can cause a drop in central vision. So I would like to differentiate, because structurally it will give us only a clue, because many times we have seen a significant GCL loss, but still the functional outcome has come. But all our COVID related vision loss did have a optic nerve, as well as there is one patient where they had a macular edema. But epiretinal membrane is something, a chronic slow process, which I doubt in 7 to 8 days will it recover. So that one doubt I had, if the patient has recovered. Probably in the chronology of events, there could have been a subclinical optic neuropathy which had recovered in the process, and we got carried away with the central field loss, which we thought could have been only because of ERM.
Apart from philosophy, I just wanted to end with another one. Today is happened to be a National Handshake Day. We can't do an handshake, but we can all say happy. It's a lovely day, Handshake Day. And then it's also a national day for post-traumatic stress disorder. So it's 2 of them are very, very coinciding with the June 27th. It's a lovely talk, I think. After a long time, I think we have had a good revision. The object of a teacher is to learn from the students very well and then carry it forwards for their completion. I think it's an excellent talk, both by PAZHANI. Kudos to you. As usual, you have shown the class. So I'm very fond of saying this: a class of people to a class of people to a class with all the classes. Thank you.
Heavy.
Yeah,
Heavy.
How
and where to go and search for this Vibji or auras?
Patient? No. It's not search for. When patient complains, you study the patient. Not search.
Mind paaka sonniye Palani எங்க போய் பாக்குறது? நானும் பாக்குறதுக்கு ரெடி. எப்படி பாக்குறது சொல்லு எனக்கு.
எனக்கு பேஷண்ட் ஆராவோட வர்ற சந்தல கலர் கேளு. அந்த கலர் சொன்னானா அவனுடைய டெம்பரமெண்ட்டை அனலைஸ் பண்ணுன்றேன்.
அப்பா to be very few handful of patients தான அந்த மாதிரி பண்ண முடியும்.
Handful. Everything starts with one observation, becomes a research sense. So you start with an observation sense, go to recording sense, get to your common sense, reach clinical sense.
எத்தனை பேர் மைக்ரேனோட வந்து கலர் எல்லாம் சொல்லிட்டு இருக்க போறோம். சரி, anyway.
I will attempt, sir. I will attempt.
We get
lot of colors.
This color business, you got the interest right from your childhood days. The colored, even the suction of the animal increases when they see the color, red color. The beak, that's a way as Ramachandran has shown that. So I would like to see, this is something which has been coming. I wanted people who have collected the auras, just look at their psychological aspect, because this is coming under, if you take any aura, by definition, it's a perceptual alteration of a consciousness in the nature. That is the objective definition of an aura. It is a perception, because that comes under cognitive factor. Cognition is nothing but perception plus thinking. So when the thinking is added, that's where the perception, when it comes, it has an effect on your behavior. That is where I was interested. People who have got a collection of auras, they look into it, whether it is really true. Because getting a purple aura is very, very difficult.
Ambika madam.
Yes, sir.
இது என்ன V2 ஏரியாவா V4 ஏரியாவா பெரிஸ்ட்ரையட்டா பாராஸ்ட்ரையட்டா எங்க வருது இதெல்லாம்?
ஏவிஏ சார் அப்படியே பிளானட்டரி பொசிஷனையும் பார்த்துடலாம்.
No. See,
astrology.
No. When you are talking about the mind and then the brain you are including, then you include astrology, means then you can look at any type of. No, you don't cross the mind. Once you cross the mind, you have only 2 things. One is intellect, the other is awareness. Both of them are beyond our scientific pursuit.
Hopefully, he's not the patient is not a colorblind person.
Hopefully, absolutely, that should be done.
Thank you, sir. Thank you very much for a wonderful evening.
Top class presentations, Palani. Thank you very much.
Thank you, sir. So I'll conclude the sessions. I thanks the chairpersons, Professor Saravanan, Dr. Kanchana, senior consultant neurologist, all my teachers, my senior colleagues, my friends. I'll hand over the mic to Professor Saravanan and Dr. Kanchana to conclude the meeting today.
Thank you, sir. Thank you very much. Thank you very much. I thank Professor Palani for having invited me to chair this section along with Professor Kanchana. I thank our senior professors and my teachers, Dr. AVS, Adesan sir and Banu madam for having taken active part and made this session very lively. And I especially want to thank Professor Lakshmi Narasimhan, Director of MIN now, for actually interacting this session and enlightening us on more on the rituximab. And thank you, one and all. Thank you very much.
Dr. Kanchana, few words before concluding.
Sir, I'm not a senior consultant, sir. First of all, I just want to, because you all are senior, you all are teachers to me, and it is happy that you have given me a chance to interact with my seniors, and with their guidance, I can do more. And Dr. Ambika ma'am, it is a very lucid presentation. It's a very exciting and challenging topic, ma'am. Really, thank you, ma'am, for the good experience. Thank you, sir. Thank you, sir.
Thank you, sir.
Thanks to everyone. We'll meet again in another meeting. Thank you very much.
Bye bye. Good night. Good night. Good night.
Good night, sir.
Good night, Gulam.
Good night, sir. Good night, everybody. Good night.
Very nice to meet all of you, sir.
Right. We'll meet again. Bye bye.
Thank you, sir. Bye, sir.
Okay. Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, Kanchana.
Thank you, sir. நான் பயந்துட்டே இருந்தேன் உள்ள வரதுக்கு, பட் திஸ் டைம் எனக்கு வந்து ஈஸியா இருக்கு. ப்ராபபிலி நெக்ஸ்ட் மீட்டிங்
யாருக்கும் எதுவும் தெரியாதுன்னு வரணும், அவ்வளவுதான்.